Thank you for the opportunity to come and present here. I think I might be one of the few speakers from out of Montreal who's come in person. And I really do think, oh, thanks. I really do think that I hate Zoom. I hate doing talks on Zoom. I think it's fantastic that COVID allowed us to become more technologically savvy and inclusive, but it's also nice to come in person. So thank you for having me. I would like to acknowledge that I live on the most beautiful, I'm totally biased, most beautiful part of the world. I live in Vancouver, British Columbia, and the land upon which I get to live and work and play and grow is the unceded territory of the Coast Salish peoples, and that includes the Musqueam, Squamish, and Tsleil-Waututh nations. And I feel very fortunate to be able to live and grow on this land. And I'd also like to acknowledge the land upon where we are today. I don't actually know the historical, the significance of the land, but I would like to acknowledge that it's unceded land. These are my disclosures. I don't think that any of these disclosures are going to impact anything within this presentation. So today, what I'd like to do is go through the rheumatic toxicities of immune checkpoint inhibitors and specifically focus on inflammatory arthritis and myositis. But then after that, talk a little bit about immunosuppression. So rheumatologists, I think we believe that we're the champions of immunosuppression. We are very familiar with many of the drugs that have been talked about already today. And, certainly in Vancouver where I work, what's been happening in the immunotherapy realm is that although oncologists tend to refer patients based on specific organ involvement, so pneumonitis goes to the respirologist, myocarditis goes to the cardiologist. Often I get involved as well because some of my subspecialty colleagues are not as familiar with interleukin-6 inhibitors and JAK inhibitors and methotrexate even, and some of the immunosuppressive medications that are being used. And so I would say that, just like lupus, systemic lupus is a multisystemic autoimmune disease that's generally thought as a rheumatic disease. I would put a plug out today that, for those of you who are referring, also think about involving your local rheumatologist because we do have that additional expertise of knowing about medications, about medication dosages, toxicity, monitoring of the immunosuppressive medications. So I will talk a little bit about immunosuppression and the very limited, very confounded data we have on the safety of using immunosuppression in the context of immune activation with checkpoint inhibitors. And then if we have time, I'll talk a little bit about people with pre-existing autoimmune disease who develop cancer and might be candidates for checkpoint inhibitors and what to do and how to approach these patients. So immune checkpoint inhibitors, as you know, are intrinsic regulators of the immune system. So they're the off switch of the immune system. And prior to the use of immune checkpoints as therapeutic targets in oncology, we in rheumatology have been using these targets in the opposite way since the early 2000s. So the first approved immune checkpoint enhancer was approved in 2006 for rheumatoid arthritis called abatacept. And abatacept is essentially a receptor with CTLA-4 attached to it that we give patients IV or sub-Q, and it essentially turns off the immune system. Because in rheumatology, we deal with autoimmune diseases where we have too much immune activation. So we've been doing the opposite of what you're doing now with immune checkpoint inhibitors. So there's a new immune checkpoint agonist that's being developed by Eli Lilly called penicillamab, which is a PD-1 agonist, which is currently in trials for rheumatoid arthritis. So as you can see, we're doing opposite things here. And in cancer therapy, as we've talked about, we're blocking immune checkpoints with immune checkpoint inhibitors to improve tumor surveillance to help to treat the cancer. So what happens when we block these immune checkpoints is we get chronic T cell activation, as has been talked about already this morning, leading to autoimmunity. And as we've already discussed, this autoimmunity can involve any part of the body, and we're still learning new and wonderful toxicities. Sometimes, as has already been discussed, the pendulum has swung the other way and that people are referred with presumed autoimmunity when it's something else. So we have to sort of always have our spidey senses on about the approach. But, often these autoimmune toxicities limit the ability to use the checkpoint inhibitors for treating cancer. And in rheumatology, the rheumatic immune-related adverse events specific to rheumatology, probably the most common are arthralgias and myalgias, which we see that in cancer. We see that with thyroid, with endocrine toxicity. We see that with metastatic bone involvement. So you can get joint and muscle pain for many reasons. What I'm going to talk about is the inflammatory arthritis, which can present similar to rheumatoid arthritis. So with an inflammatory polyarthritis, inflammatory monoarthritis, a polymyalgia rheumatica-like, which for those of you who remember back to, I'm assuming most people are not rheumatologists in the room. So polymyalgia rheumatica, shoulder and pelvic pain and stiffness, reduced mobility. Myositis, which can be severe and life-threatening, and then a whole array of other rheumatic things like sarcoid-like reactions, vasculitis, worsening osteoarthritis. We're seeing a little bit more capillary leak syndrome, which I'm not sure I would call that rheumatic. We've just recently described in our national cohort acrovascular cyanosis, which again, not sure we call that rheumatic, but there's all different autoimmune things that kind of encompass traditional rheumatic diseases. And so what are the principles of treatment? Now, as a rheumatologist seeing a regular idiopathic patient with rheumatoid arthritis, my goal in that patient is remission. I want them to come back and tell me, Dr. Jamal, I don't have arthritis. I feel totally fine. I have no joint pain, no swelling, no stiffness, normal function. Now, when I see patients with checkpoint inhibitor-induced inflammatory arthritis, it's not the same. I am not targeting remission of their arthritis in these patients. I'm targeting improvement and, optimizing their quality of life, understanding that I also, the target here is to treat the cancer, right? And sometimes treating the cancer, as we've heard, and treating the autoimmune toxicity are opposite. So if you suppress the immune system to treat the autoimmune toxicity, you might negatively impact the ability of the cancer to respond. So it's a flip switch in my mind. And I think, for those of us who are managing toxicities, I think all of us feel somewhat similar in that the goal is not necessarily remission of their toxicity, but it's to optimize treatment of the toxicity to allow the oncology therapy to continue. And so this is something, again, where collaborative care is important. It helps me when I get when I get a referral from an oncologist. If I understand that this patient, their treatment, it's curative intent, that makes a big difference. If this cancer can be cured, then I might be less aggressive with my immunosuppression, or versus if it was adjuvant intent versus if it was, palliative intent. And I think that, these types of things, each patient is different. The other thing that's been talked about already, and I'm going to reiterate today, is everything that we do to identify and treat these patients is really based on observational data. That is, people are done, you see a patient in front of you, you treat them with whatever you think is going to be the right option, and you're like, oh, wow, it worked or it didn't work. And then a bunch of people put a bunch of cases together, describe it, and now it's the word of law. So that is very confounded and biased, right? So, what we've been doing with toxicity management is we're really, and we see this in all of the talks, we're using the therapies that we traditionally use in our idiopathic diseases, and we're applying these therapies to our patient with autoimmune toxicities. We don't know if that's the right approach. We're just doing what we always do. And so that's why when you look at, for example, inflammatory arthritis, psoriasis, methotrexate is commonly used in checkpoint inhibitor-induced inflammatory arthritis and psoriasis. Whereas when you see inflammatory hepatitis, ICI hepatitis, or ICI myositis, you might see more mycophenolate. Why? Because mycophenolate is used more in the idiopathic versions of these diseases. But maybe mycophenolate would be a better option for all, or maybe methotrexate. You know what I mean? So that's a big challenge, is there's very little RCT data on how best to manage these toxicities. Now, I think I'm speaking to a room of oncologists. And one of the big things that immunotherapy has changed, I think, my impression in the oncology world, is now cancer is becoming a chronic disease. Similar to rheumatic diseases, patients with palliative intent treatment are living for 10 years. I can't tell you how many patients with lung cancer I've been following for 5, 6, 6, 7 years. And they've had their checkpoint inhibitor. Some of them are still on it. Some of them are on it. Then they stop it. Then they have progression on a PET. Then they get restarted on it. And it's this chronic disease thing. But then they have a toxicity and nobody knows how long they're going to be on treatment for their toxicity or for their cancer. So it's this world that we're now starting this whole new horizon. We all have to work together to design good clinical trials so we can optimize how we treat patients. With that said, I'm going to talk a little bit about some of the toxicities that I see. So inflammatory arthritis. So I would say this is probably the most common rheumatic, aside from arthralgia, myalgia, but the most common toxicity that we see in rheumatology. And it's not the same as our idiopathic diseases. So it's not the same as rheumatoid arthritis or psoriatic arthritis or traditional PMR. It's not the same because, well, first of all, it seems to affect everybody similarly, males and females. It doesn't have a gender predilection, whereas some of our traditional idiopathic diseases tend to occur more commonly in women. Every patient seems to present differently. We see very similar to rheumatoid, so the classic, symmetric small joint polyarthritis. We see large joint monoarthritis, sometimes very refractory to treatment. We see the PMR-like pattern. We've described an RS3PE-like pattern where remember RS3PE? Who remembers RS3PE from med school? Probably very few. That's a symmetric synovitis with pitting edema. So often they come with quite a bit of pitting edema. Important things that we have to think about. I've been referred patients because, joint symptoms, post-checkpoint inhibitor must be a rheumatic toxicity. Go see Jamal. So I get them referred to me, and I've seen people with, cancer in their joint. So, you aspirate the joint. If it's a monoarthritis, and boom, there's, squamous cell carcinoma cells in there. I've seen people with fractures, medial plateau fractures or metastatic bone involvement of their cancer with fractures presenting with acute swelling and pain in a knee. And so again, we do have to look at other causes. The interesting thing with these is they tend to be seronegative. In fact, we're currently developed classification criteria, and patients who have positive serology, so rheumatoid factor or CCP positive, many people feel that potentially those are patients with undiagnosed pre-existing predilection or subclinical rheumatoid who are unmasked potentially when they got their immune checkpoint inhibitor rather than true immune checkpoint inhibitor induced arthritis. The one thing that we're noticing is that these patients typically require more immunosuppression than what we're used to. Somebody with rheumatoid arthritis, classic seropositive rheumatoid arthritis, often 20 milligrams of prednisone and it melts away. They tend to be very steroid responsive. Similarly, PMR, 10, 15, 20 milligrams of prednisone and seems to melt away. The very first patient I ever saw with an immune checkpoint inhibitor and induced inflammatory arthritis needed 100 milligrams of prednisone, and even then was still having to crawl up and down stairs. That said, that's not common, but in general, it's been found that the immunosuppression requirement to treat these patients is somewhat higher than what we see in our idiopathic diseases. And it seems sort of with the inflammatory arthritis, it seems to walk to the beat of its own drum. So once you've induced this autoimmune process in the joint, regardless of what happens to the checkpoint inhibitor, it seems to continue. So stopping, holding, or continuing the immunotherapy hasn't had as much of an impact necessarily as potentially in other toxicities like potentially skin or gut toxicities where holding the checkpoint inhibitor sometimes makes the symptom improve. But like other toxicities, those who develop inflammatory arthritis tend to also have a favorable tumor outcome. And I suppose that's because you activate your T cell, you have a chronically activated T cell that's doing its thing for the cancer, and you get a toxicity, well, it's shown that your treatment's worked, right? So that's always the silver lining that I tell patients. So the other thing, and this is Alexandra's, she's sitting up there in the audience. Alexandra has reported this. It was published in January, and we've shown this here in our Canadian data, is that the inflammatory arthritis, different than maybe some of the other toxicities, once it starts, can be chronic. And I think this is important, again, as an oncology person to understand, because although the inflammatory arthritis is not as common maybe as other toxicities, it can significantly impact quality of life. And I've seen a number of patients who received checkpoint inhibitors in the adjuvant setting for, say, melanoma or something, and they develop this chronic inflammatory arthritis, and they're really mad because this arthritis has not gone away. Everything else has gone away, and now they're limited in terms of their ability to function and enjoy their remainder of their life that they now have because of this arthritis. And certainly our data in Canada, we have data on 120 patients who had stopped with 3-month data post stopping their checkpoint inhibitor. And out of these 120 patients, 90% or close to 90% still had ongoing inflammatory arthritis. And our data on the 73 patients we have 2 years since stopping their immune checkpoint inhibitor. And out of those, nearly 50% still have inflammatory arthritis. So, now that we're curing patients or putting them into effectively complete remission or partial remission for a long period of time, and now that cancer is becoming a chronic disease, those who develop arthritis, there is this potential of long-term toxicity. And that's something I think that's important to counsel them about when you're starting them, that if they do develop some toxicities, they might be chronic, even though the cancer itself is in remission. My very first patient, the guy who I was talking about who had to climb up the stairs that needed 100 milligrams of prednisone, that was in 2013. So well, let me tell you, 12 years ago now, 12 years ago. His melanoma is in remission. PET scans are clear, but he's still on 25 of methotrexate. And interestingly, he has vitiligo and inflammatory arthritis. And last year, we reduced the methotrexate because he's been in remission for so long. And after reducing the methotrexate from 25 to 20 milligrams a week, so that's not a very big reduction, his vitiligo progressed. He had this worsening vitiligo and his inflammatory arthritis came back. And so in September, we increased it back to 25 milligrams and he's back in remission. So, I don't know. He had some sort of immune activation, which has really done well for him from a melanoma perspective, but he has this chronic autoimmune toxicity. As we've talked about, the correlation between the immunotherapy-induced inflammatory arthritis and tumor response. This is data from the United States from Hopkins. The red line on top, I don't know if that projects well, that's people who developed persistent arthritis, and those are the people with complete and partial remission. Those who did not have persistent arthritis had to have more tumor decline. So, persistent arthritis, although it's a potential high toxicity, it is associated with better tumor outcomes. And this has also been shown here in our Canadian data that Alexandra published in January. And the people with chronic inflammatory arthritis, you can see in the red line, had higher progression-free survival compared to those who had the acute arthritis that resolved. So that's the silver lining. Ongoing immunotherapy, most people either pause or continue. The decision to stop or start immunotherapy, to me, is more so dependent on the degree of immunosuppression rather than the inflammatory arthritis. And I often see patients still, and I ask them, what's the plan? Are you going to have your immune checkpoint inhibitor? Oh, Dr. Jamal, that depends on you. And I was thinking, me? Why do I get to decide? And often it's, I guess it doesn't make sense. If you're giving somebody 50, 60 milligrams of oral prednisone, so you're suppressing their immune system, it doesn't make sense to activate and suppress at the same time. So that to me is the reason that I would say would hold their immunotherapy until they're on a lower dose of prednisone and then can resume immunotherapy. There was one study looking at melanoma patients that compared people who held their immunotherapy versus those who continued it throughout their toxicity. And there didn't seem to be a difference in terms of their melanoma outcomes. And in those who had progression, who had held their immunotherapy, once it was restarted, they seemed to recapture a good response. So, that decision is really a case-by-case basis, but I'm not usually fussed about whether it starts or stops. And again, Alexandra did this work in France, looked at 23 patients in France who restarted their checkpoint inhibitor after having a toxicity. So they developed inflammatory arthritis. They stopped their immunotherapy. The inflammatory arthritis was treated and doing well. When they restarted their immunotherapy, about half of them flared. So the flare rate was pretty good, and it flared pretty quickly. However, it responded to treatment, and it didn't impact their long-term checkpoint inhibitor use. So this is a small sample size, but that is something to keep in mind when restarting immunotherapy. So summary with inflammatory arthritis, it is different than idiopathic inflammatory arthritis. We have a high risk of chronicity, which I think is important when counseling patients and starting their checkpoint inhibitor. It is associated with better cancer outcomes, the silver lining, and there is a risk of it coming back after restarting the checkpoint inhibitor. Next, I'm going to talk about immune-related myositis. Less common, but more important, I would say, and maybe more severe. So it's a rare but serious side effect. And again, variable presentation. So some people can have very mild myalgias again. And often, this is something that you monitor when you're doing their cycles, right? So my understanding, at least in BC, and I'm assuming here as well, is CK is part of your pre-cycle blood work when giving somebody an immune checkpoint inhibitor. And so this is something that often their CK can go up and they have no symptoms. And then you can, find subclinical myositis, to fulminant, weakness of everything, including respiratory muscle. So it has variable presentation. Sometimes it's hard to differentiate from other symptoms of cancer. So, weakness, fatigue, myalgia, dysphagia can be from hypothyroidism induced by your checkpoint inhibitor or other endocrinopathies. It can be from metastatic cancer. So you need to think about it. One of the unique things in immune therapy-induced myositis is this neck extensor involvement, which is becoming increasingly described. So traditionally, idiopathic dermatomyositis or polymyositis, typically it's neck flexor, shoulder and pelvic muscle weakness that we see. But in the ICI myositis, there's this neck extensor involvement, which is a little bit unique. The rash is uncommon, and the traditional antibodies we see with dermatomyositis are usually negative. So this is its own thing. I think when seeing patients with ICI myositis, is everybody here familiar with the triple M? Everybody heard of triple M? This is the thing that, I think is really important. The one pearl I would take away from my talk is when you see somebody with CK-itis going up as part of your screening blood work, when you're having them assessed for potential ICI myositis, always look for myasthenia gravis and myocarditis. Why? Because the mortality of combination, the triple M, is quite high. And those who have myositis, myocarditis, mortality of 50%. So it's important to identify early. It's important to treat because it can rapidly progress and then sometimes be very refractory to treatment. So the myasthenia gravis, as part of this, I'm just going to put this out. I think the best way to when you see somebody with myositis, because myositis is what you'll probably find because you're checking a CK, right? You're checking a CK, and CK is going up. They might be weak. Ask about bulbar symptoms. Ask about these symptoms. It's not something that I think most of us commonly do. Ask about swallowing, facial palsy, double vision. Look at their gait. If you have an index of suspicion, have your EMG neurology colleagues involved. The antibodies are not always reliable, so the tests that we normally do to look for myasthenia gravis are less reliable in ICI myasthenia gravis. So it's really important to have your neurology colleagues involved if you're suspicious. I had a patient once with myositis and he had this droopy head, like he came in like this and he was, like this. And then he also had ptosis, but you couldn't tell. So he would go like this and his eye is, it was this very interesting clinical presentation. And I said, I think he has ptosis, but I couldn't see his eyelids. And so, I had him see one of my neurology colleagues and sure enough, he had myasthenia gravis. And, that changed management in that we were a bit more vigilant, a bit more aggressive in terms of treating this gentleman. So myasthenia gravis, when there's respiratory involvement and that presents with hypercapnia, can be life-threatening. So it is important to identify. And then the myocarditis. I'm not going to talk a lot about this because I know there's another talk on checkpoint inhibitor cardiomyopathies. But myocarditis is something I think that we all need to be aware of. Maybe 2 or 3 years ago, there was a patient who had presented to BC Cancer for their regular checkpoint, I think it was pembrolizumab infusion. And at that time, their CK was, I think, had gone up to 700 or 800. They were asymptomatic, but they were sent straight from their infusion to the emerge. And they're sitting in emerge waiting to be assessed for ICI myositis because the oncologist thought they needed to be admitted for IV steroids. And while in Emerge, the patient died. And they died because they had an arrhythmia. And they had an arrhythmia because they had asymptomatic myocarditis. That they were not on a telemetry bed. They didn't have any symptoms. And so I think this is, again, a dramatic case. It was talked about in M&M. We did an M&M rounds about this. But it's something that is seen, the silent, the arrhythmias, and has been talked about already, is when you see somebody with an elevated CK, even if they have no cardiovascular symptoms, I would at least get a troponin and get an ECG. So those would be the two tests that you can do as sort of screening tests, because troponin, more than 90% of cases of ICI myocarditis, troponin is elevated, and same thing, ECGs can be abnormal. Echoes are not a good test. Echoes have been normal in 50% of the cases. And so if you do have an elevated troponin, and I have seen this in a number of cases I've had with CKitis, and I check their troponin and it's elevated, and get an ECG, it's normal. I'm like, okay, we get an echo, it's normal. And then we get a cardiac MRI, and lo and behold, there's myocardial involvement. And again, our treatment of these cases might be different. We're monitoring differently for arrhythmias. We're treating them more aggressively, and it's important to identify. Here's a case that was reported in the literature, that a patient who went from heart block to VTAC and died in 3 hours. And so patients with myocarditis, we do have to be vigilant and look for it. In one cohort of patients, 38% of people who died had a normal echo. So echo is not a good test, and MRI is really what we need to be advocating for. And again, I don't know what the access is in other parts of Canada and the world, but in BC, I have to advocate for an MRI because they're like, echo is normal. And then I have to get the cardio oncology cardiologist to okay me getting an MRI urgently, because some of the general cardiologists or the CCU cardiologists might not be familiar with this. So it's up to us to advocate for these patients. So ICI myositis summary, like I said, variable presentation, neck extensor involvement common. You guys are already screening with CK, but you should also screen for myasthenia gravis and myocarditis with a troponin and ECG and an MRI if you have that suspicion. So then I talk about immunosuppression. So this is what we are doing. I don't know if you can see. Okay. So when we don't have a naturally occurring the immune checkpoints, turn off the T cells. What we're doing is we're activating that T cell. And we're hoping that this activated T cell is going to do its anti-tumor function and therefore take care of the tumor, kill the tumor cells. But we also know that this activated T cell is also activating other immune system cells, so B cells, macrophages, and other cells. What we don't know is what signaling is being used for which function. Is it the same cytokines that are activating the macrophage T cell, like interleukin 1, interleukin 6, TNF alpha? Are those the same cytokines that are being used for the anti-tumor functions of the T cell? And the reason that that's important is because some of our therapies are targeting these cytokines. And when we target these cytokines, we want to ideally target cytokines where the autoimmunity is going to be impacted, but the efficacy is not. And how do we do that? We don't really know to date. And the challenge is when you develop an acute toxicity and you treat it for a short term, that's one thing. But when you develop a chronic toxicity, like inflammatory arthritis, for example, if you chronically suppress these cytokines, are you doing a disservice to their tumor or to their cancer treatment? And that's always the big $1 million question. So as we've already talked about, there's no prospective RCTs on optimal immunosuppression. And as I've mentioned today, what we're traditionally using is what we use with our idiopathic diseases, which come with a similar phenotype. So we don't know what the best immunosuppression is. None of us do. There's no trials. We've had observational studies which are very confounded and biased and with very different therapeutic results. So my preceding speaker talked about IL-17 blockade for treatment of psoriasis. But the very first case report of an IL-17 inhibitor used in a person with a checkpoint inhibitor toxicity, the patient died. And so, there's been this this hesitation on the rheumatology end to use IL-17 inhibitors for rheumatic toxicities because of this one case report. And so that's sort of where we do need to realize patients with cancer will die. They have metastatic cancer. We do realize that N of 1 doesn't mean everybody. And we've all had cases of a bad experience with an agent and it makes us gun shy to use it again, but we don't know what the optimal use of immunosuppression is. The emerging literature, as again has been also talked about by my the dermatology speaker, is that the earlier we immunosuppress after starting an immune checkpoint inhibitor, the less the immune checkpoint inhibitor will have time to activate the T cell to treat the cancer. So we want to delay immunosuppression if possible. Now, as a rheumatologist, as I said, unless I have myositis or myocarditis, arthritis is not going to kill people. It's going to kill their quality of life, but it impacts quality of life, but not, it doesn't impact mortality. So if patients can manage or tolerate symptoms, I will often have that discussion with them and say, can we delay starting your immunosuppression? Yes, I know that the arthritis is, you can't brush your teeth, you can't dress, but can we delay putting you on something to modulate or suppress your immune system at least 6 or 8 weeks after you've had this checkpoint inhibitor exposure? So the things that I think about when talking about treatment is how bad are their side effects? So can they live with it? What is the patient preference? And what is their cancer? Is this a curative intent, palliative intent, adjuvant? Are there other options? Because each case is different. And like I said, data from observational studies, and we've already talked about prednisone. We want lower dose, shortest duration prednisone. The data on prednisone is higher than 20 milligrams, has been shown to have a negative tumor response. Lower doses, less so, but we don't have great data. And again, it's all confounded. So on the one hand, having an immune-related toxicity improves your prognosis. And on the other hand, having prednisone reduces the prognosis. We don't have good data on people who develop an immune-related toxicity. Compare those who get prednisone and don't get prednisone, because I think that's the question, not overall, because if you have a toxicity, your prognosis is better. If we immunosuppress you, does that make your prognosis worse? We don't know. So far, the data with the less potent drugs such as methotrexate, hydroxychloroquine, sulfasalazine, mycophenolate, those are likely safe. Biologic DMARDs like infliximab, interleukin 6 inhibitors, JAK inhibitors, there's less data, but those seem to have a little bit more data that there might be a less robust tumor response. And again, most of the studies look at short duration treatment with a biologic. So most of the colitis studies, people get, infliximab 1 to 6 doses. They don't get infliximab for 10 years. And like I said, in rheumatology, we're seeing these patients develop arthritis for 10 years. 10 years, maybe longer. And so is it safe to give them a biologic for 10 years in terms of their tumor? And that's the million-dollar question. So myositis, triple M, because it can be life-threatening, we want to be aggressive in terms of treatment. So the high-dose steroids, IVIG. The drugs that are most commonly used and reported are mycophenolate and methotrexate. I'm not going to say that they are the optimal drugs. It's just because those are the ones that we always use for idiopathic myositis, and that's why they've been adapted. And there have been lots of case reports of advanced therapies like TNF inhibitors, IL-6 inhibitors, JAK inhibitors, plasmapheresis, and then in patients with life-threatening disease. So abatacept, remember the drug I talked about in the beginning, is a T cell. It augments their checkpoint inhibitor. Abatacept, alemtuzumab, another T cell directed therapy, have been used successfully in refractory life-threatening myocarditis. B cell directed therapies have been found to be less effective in these patients. Looking at tumor outcomes. So this is a study looking at inflammatory arthritis, comparing methotrexate, a TNF inhibitor, and an IL-6 inhibitor. And it's hard to see the colors, but on the very left is blue is the TNF inhibitor, the red is the IL-6 inhibitor, and the green is the methotrexate. And you can see here, this is the response of the arthritis. You see that the TNF inhibitor, interleukin 6 inhibitor, worked faster and better than methotrexate to treat the arthritis. However, if you look at their progression-free survival, those who got the TNF inhibitor and the IL-6 inhibitor had lower progression-free survival compared to those who got methotrexate. So again, nothing is without risk. It might work better to treat the arthritis, but there might be a negative impact on progression-free survival. So that is something that I always tell each patient, and then decisions are made case by case. And this is looking at across IRAEs, a study looking at immunosuppression from 606 patients in 18 countries. And what they found is regardless of the type of immunosuppression, there was reduced overall and progression-free survival in patients who were treated with immunosuppression, including corticosteroids. And the earlier they got exposed to their immunosuppression, the worse their outcomes. And so again, it's this delay as much as you can to treat with immunosuppression. In this study, most of the immunosuppression was TNF inhibitors, so I'm assuming a lot of them had colitis, mycophenolate, so I'm assuming pneumonitis, hepatitis, tacrolimus, and then IVIG. And IVIG, I don't know if I would classify that as immunosuppression, but they did in this particular study. So, again, the data we have is quite confounded. Now, how are we doing? Are we okay for time? Okay, I will quickly touch on pre-existing rheumatic disease and checkpoint inhibitors. I added this in at the end because it's a question I get often from my oncology colleagues and my rheumatology colleagues. So, as most of you probably know, patients with pre-existing autoimmune disease of any kind were not included in the trials of checkpoint inhibitors in cancer. And so the data that we have in these patients comes really from clinical practice. The general consensus, and we have EULAR, the European League Against Rheumatism, developed a consensus and guidelines on optimal management of pre-existing autoimmune disease. And the general consensus is that our patients should still be offered checkpoint inhibitors, right? So, patients with rheumatoid arthritis, for example, often smoking is a risk factor for rheumatoids, and smoking is a risk factor for cancers that are treated with checkpoint inhibitors like bladder cancer, lung cancer, et cetera. So, I've had a number of my own patients and my colleagues' patients who have stable, long-standing rheumatoid who get diagnosed with renal cell carcinoma or something else, and are being offered a checkpoint inhibitor. And the question is what to do with these patients. So number one, does immunotherapy work in these patients? Because they were excluded from the trials. The very, very minimal, again, confounded biased data that we have suggests that yes, they do. And in earlier times, so 10 years ago, many patients with a pre-existing autoimmune disease might not even have been offered a checkpoint inhibitor when they got diagnosed with cancer because they weren't included in the trials. Now I think it's more and more. I saw a patient 2 days ago, urgently referred. She has lupus. She had lupus with lupus nephritis, has a transplanted kidney, and she developed renal cell carcinoma in her native kidneys, which were removed. And now she has renal cell carcinoma and the transplanted kidney, which has now since been removed. And she's back on dialysis, but she's got metastatic renal cell carcinoma. So the question is, can we treat her with a checkpoint inhibitor in the context of having lupus? And so I had to see her urgently on Wednesday. And when I saw her, her only lupus was in the kidneys. And I was like, well, you have no more kidneys, not a transplanted one, not a native one. And, so I would treat her because she's going to die of this metastatic renal cell carcinoma. And if she has a flare of her lupus, we will deal with it, and this is, but again, case by case basis. So looking at the data that's available, it does seem like these patients respond. There is a risk as we activate their immune system that when they have an underlying autoimmune disease that it will flare. So most of the studies that we have, about 50% risk of flaring. And in our Canadian data of 102 patients, there was no difference in people who flared if they were or were not on baseline immunosuppression for their pre-existing autoimmune disease. So if you have rheumatoid arthritis or lupus and you're on immunosuppression, the question is then, what do we do with the immunosuppression? Somebody's on methotrexate and infliximab for rheumatoid arthritis. Now they have metastatic cancer. I've just told you that immunosuppression when starting the checkpoint inhibitor might impact the ability of the checkpoint inhibitor to work. Well, what about people who are on it at the time for a pre-existing autoimmune disease? And the question and the answer is yes. We have shown that people who are on baseline immunosuppression, they likely have less good response to their immune checkpoint inhibitor for their cancer. but it doesn't seem to prevent them from having a flare of their pre-existing autoimmune disease. It might reduce de novo toxicities, autoimmune toxicities, but that's not been shown everywhere. We've shown it in our Canadian data, but 2 American studies did not replicate that. So we really don't know. And this is, if you look at the numbers, it's so small. These case reports and case series are 25 patients, 35 patients, 100 patients. And again, it's confounded, confounded by who's getting offered checkpoint inhibitors. It's usually people with standard, stable, non-life-threatening other pre-existing autoimmune disease. I'm going to skip this in the approach of time. So when I'm seeing a patient with pre-existing autoimmune disease who's got metastatic cancer and I'm being asked what to do with this patient, first of all, I think it's important to offer them, if cancer could kill them, if they have metastatic cancer and it could kill them, then I would think it's important to offer them the checkpoint inhibitor. If the checkpoint inhibitor is being used in the adjuvant setting, or maybe in a neoadjuvant setting, like say, for example, triple negative breast cancer, where potentially the additional benefit is not necessarily as much as, say, for melanoma, then I think that discussion has to be had with the patient, that there's a risk of your lupus flaring, and we have maybe a 15% mortality benefit adding this to your breast cancer, then the patient can decide. I think it also depends on the kind of pre-existing autoimmune disease and how bad their initial manifestations are. If it's a patient with scleroderma who has lung involvement and, versus a patient with skin and joint lupus, if they flare, then we can easily treat the skin and joint lupus. But maybe if they have pulmonary hypertension and ILD with their scleroderma, a flare of that might be actually more life-threatening than their cancer. So it's really underlying disease, thinking about if we stop their immunosuppression prior to starting their checkpoint inhibitor, we have to think about what is the implication. Will their disease flare? And how is that going to impact their ability to continue getting their cancer treatment? And so often it's this discussion we have with the patient, with the oncologist, and often with their treating rheumatologist, because it's often not me, about what their disease course has been, how hard has it been to get them into remission. But knowing that having a DMARD at the time of starting their ICI, it might not prevent flares and it might impact the ability of the immunotherapy to work. So these are the questions we have, and these are the discussions that I have with my patients. And again, this is looking at baseline versus no baseline immunosuppression from our Canadian data. And you can see the ones in red had no baseline immunosuppression, and they had better overall survival and progression-free survival when treated with checkpoint inhibitors. So again, we want to minimize immunosuppression when starting your checkpoint inhibitor. And similarly, this was found in a study in France. We do have recommendations that are going to be published on management of pre-existing autoimmune disease that we've developed in Canada. And so stay tuned. This is currently submitted, not accepted for publication, but hopefully will be soon. And they're 2-part for autoimmune disease. So underlying key takeaways, I would offer people with pre-existing autoimmune disease a checkpoint inhibitor if that's what the optimal treatment. There is a risk of having an underlying disease flare and potentially higher risk of a de novo IRAE. We do want to minimize the immunosuppression when starting the checkpoint inhibitor, and there is no role for prophylactic immunosuppression to prevent a flare. And finally, my key takeaways from today, rheumatic toxicities can have variable presentations. They often mimic idiopathic diseases. Inflammatory arthritis can be chronic. In people with ICI myositis, remember to look for triple M. When using immunosuppression, try to minimize the dose and the duration and try to delay it as much as possible. And please continue to offer people with rheumatic pre-existing disease checkpoint therapy. These are my co-conspirators, collaborators that we do research with. And please do check out our CAN-RIO website. We do all kinds of interesting things, refer patients. And here you go. Thank you.
So I will take the moderator's prerogative and ask the only question. I will ask you a question, but just because I have some inside knowledge and I want to give you a sense of how Shahin is really helping us or leading us towards doing this better. All of this is what's published, what's out there. But and for any of you who may have had a patient with colitis, you know that we give infliximab IV, n'est-ce pas? But, I wonder if you would share with us your idea of in arthritis patients, whether there's a role for intra-articular anti-TNF.
Oh, yes. Thank you. So yes, I have used intra-articular. So TNF inhibitors are being used in colitis. We have a study that we're doing now, a clinical trial looking at, we kind of said, hey, these colitis patients are not developing chronic colitis, but arthritis patients are getting chronic arthritis. Is it because colitis is treated with IV steroids at the beginning, infliximab, 1 to 3 doses? Is it turning off the immune response? So we are actually in the middle of doing a trial right now looking at induction TNF inhibition in patients with de novo inflammatory arthritis for 3 months, comparing to usual caring and seeing if it can reduce the chronic inflammatory arthritis. That's the one thing. But the other thing that we've been doing a lot of in Vancouver is intra-articular TNF inhibition. And we have found in people with one really inflamed hot joint that needs 50 to 100 milligrams of oral prednisone. When I inject adalimumab or etanercept into the joint, it's turned off the inflammation. And often then those are in people who have synovial hyperproliferation. So that's something that we're talking about publishing, and we just have I have a student comparing publishing rheumatoid arthritis intra-articular TNF to ICI intra-articular. But it is a strategy that to consider, especially with ultrasound guided injections. That's the only way I would do it. So yeah, totally off label.